We want to thank Harborview for hosting us here. It's well known not just for trauma care. The goals of our meeting are, we'd obviously like to try to update you on the assessment of deformity, update you on treatment options, in which there's some very exciting things taking place. We very much would like to try to link pediatric and adult spinal deformity perspectives, which has been an elusive problem, and discuss controversies with your help. This introductory remark could also be identified as scoliosis, scamnum, or succussion. I think this mysterious phrase warrants a brief explanation. If we talk about scoliosis, over the history of time, humankind has been somewhere vacillating between fascination and revulsion, as evidenced by the Hunchback of Notre Dame and Venus de Milo, who I insist had idiopathic scoliosis. As we look at patients, again, we see the same reflection of differences in patients in quite a dramatic degree. And if we go back to the words of a well-known physician, he stated, "There are many varieties of curvature of the spine, even in persons who are in good health, for it takes place from natural conformation and from habit." And that was Hippocrates himself around 400 before Christ. If you look through history, again, back in ancient Hindu texts, Lord Krishna was said to press down on feet and pull up on the chin to correct scolioses, and apparently turned women who are crippled into beautiful young ladies. The outcomes were fantastic. The long-term follow-up, however, was unknown, a practice that pervades modern medicine. If we look at the scamnum aspect, that was a treatment suggested by Hippocrates, who we talked about before, a basically lengthening table. And the debate at the time was the succussion, which was basically strapping a patient upside down and shaking them until their spine straightened out. So Hippocrates is credited with having damnified the succussion therapy. Sadly, spinal deformity therapy for over 2,000 years has basically stayed in the scamnum or succussion argumentation. It has not gone very much further. And most patients were basically treated with ignoring the disease process. And unsubstantiated treatments pervade it. It's only over the last 50 years that we actually have had the chance and the power and the gift to change lives by straightening people out again. And it is a true gift that has brought us into many evolutions where we can actually recontour a spine into physiologic parameters now. We're far from being perfect, but it's a drastic change. Sadly, in the evolution, we've split between pediatricians and adult surgeons, and this is a chasm that persists up to the present date with some difficulties as we don't communicate very well with one another. However, if we look at patients, it's a human continuum that we'd like to somehow bridge. And so if we go and take this title further, hopefully this will be a session that leads us beyond scamnum or succussion, where we encompass all the phases of mankind as shown in this picture on the left-hand side, from youth to intermediate to aged people. So I turn over to the moderator, Randy.
Good morning. I think we've got an excellent faculty, and hopefully during the discussions here we will have time to interact. And then also, one of the nice things about the labs at the end is it's a great time to talk about things while you're doing the procedures, while you're interacting with your teachers. It's a great time to ask questions you've been wanting to ask and get to know our faculty. I'd like to kick things off here and welcome James Wilson McDonald to come up and start things off this morning with thoughts on the etiology of kyphoscoliosis.
Thank you. Well, thank you very much for inviting me to come to this meeting. It's very exciting, and I think I'm going to enjoy it very much. I've been asked to start by talking about the etiology of scoliosis. I think if we'd had this talk 10 years ago, we'd have had a very short talk, and there's certainly been some more information come available over the last 10 years. First of all, what are we talking about? What is it? It's a combination of hyperlordosis, lateral curvature, and rotation. And of course, it's mainly the rotation that the patients don't like. So if we look at the bending film, we see typical rib hump. The patient's overall in balance, maybe slightly off balance to the right. And when we look at the side view, it looks as if we've got a very kyphotic patient, but of course the spine itself is hyperlordotic. And if you look at most patients, almost all patients with idiopathic scoliosis, that part of their spine will be hyperlordotic. If this is a syndromal child who had a posterior fusion many, many years ago, and this is almost an experiment because here you have a posterior fusion, and of course the anterior spine goes on growing, and the effect of that is that there's nowhere for this spine to grow to, and so it rotates round and you end up with this enormous rib hump, as seen here in the patient. Again, look how lordotic the spine itself is. If you look at the pattern of spinal shape, patients with scoliosis have a very low kyphotic angle, and patients with Scheuermann's obviously have a very high kyphotic angle, with normals somewhere in between. If you look, we know that idiopathic scoliosis is much commoner in girls, and if you look at girls, they're growing at a time when their spine is relatively lordotic. Whereas if you compare that with boys, boys have their growth spurt at a time when the spine is becoming increasingly kyphotic. And that may explain the high incidence of scoliosis in girls and the high incidence of kyphosis in boys. Here, this is just a reproduction of what you've just seen, with the girls stopping their growth much, much earlier than the boys. If you look at the spine, you can show that there is very high pressure over the convexity of the curve, which is exactly what you would expect logically. And this may be one of the drivers which makes the curve progress in the long term. So if you look at it, as the scoliosis progresses here, you can see that there's a very high area of pressure on the concavity. And we'll talk a bit more about that later. So this is a very simple model, which really helps to explain why you get scoliosis. At the front of the spine, you have a bar, and at the back, you have a tension band. So in the neutral position, you have no curvature. But if you lengthen the front, you can see you start to develop a lateral curvature, and you start to develop rotation. And then if you increase it, the rotation and the lateral curvature becomes greater. And if you take an oblique view of this part of the bar, it is in fact lordotic and not kyphotic. So a very simple model helps to explain what's going on. Now, there have been a number of investigations over the years trying to explain why scoliosis occurs. Here's one where they looked at the musculature in the spine, and they found that the multifidus was much shorter on the concave side, with more slow twitch fibers. And their conclusion was that this may be an explanation of why scoliosis develops. I think equally it could be a result of the scoliosis rather than the underlying cause. We look at biomechanical and neuromuscular factors. There is evidence that there may be a defect in neuromuscular control, and that biomechanical factors then go on and affect progression. It's been known for many years that if you take the pineal out of chickens, they will develop scoliosis. And it's thought that this is due to the melatonin levels in the blood. And this group took 3 groups of chickens, and they either gave them melatonin, serotonin, or control. And in the control group, there were much higher levels of scoliosis. And when they looked, when they actually measured the melatonin levels, they were lower in the chickens with scoliosis. So it may be that this is part of the control of spinal growth. Other people have looked at the actual shape of the spine. Burwell and his co-workers in Nottingham were of the view that you need coronal asymmetry in order to drive the scoliosis. They pointed out that it's not a kyphosis, it's a lordosis, and it's the opposite of Scheuermann's disease. Whereas Dixon and Milner in Leeds felt that it was nothing to do with coronal asymmetry, and that the driving factor was the lordosis, with the spine buckling, as I showed you in that second syndromal child with the posterior fusion. There have been other studies looking at the neurological function of children. For example, this study looking at labyrinthine function. And they found that the children with scoliosis had a very high incidence of nystagmus. Around 50% of them had nystagmus, whereas in the control group, about 2 or 3% had nystagmus. And they looked at the caloric response of the labyrinth and found that there was a significant difference on the side of the scoliosis. But they weren't sure whether this was a cause of the scoliosis or whether it was the effect. And then finally, the people who looked at the modeling of the annulus fibrosus and have shown that there is asymmetry in the annular fibers. And again, it's thought this could be a driver for scoliosis. I suspect it's probably a result of the scoliosis rather than the underlying cause. There was a paper at the SRS recently showing that if you put pressure on the spine of a rabbit, you can induce a typical scoliosis. Jeremy Fairbank, my colleague who was here last year, has done intradiscal pressure measurement in idiopathic scoliosis. And what they've found is that on the concavity, the pressures are very high indeed. Of course, this is probably effect rather than underlying cause. And their conclusions were that disc cells probably respond very sensitively to pressure changes, and that proteoglycan and collagen synthesis may well be altered because of the mechanical environment which the disc is in. And their conclusion was that this could lead to matrix changes within the disc and to wedging and progression of the deformity. And that asymmetry might make this quite a lot worse. I think some of the most exciting developments, though, now are in identification of different chromosomes which have been linked to scoliosis. And there are now about 9 or 10 chromosomes which have been shown to be linked to scoliosis in family groups. This is just one of them. This is a study from last year where they looked at 202 families where there were 2 or more individuals with idiopathic scoliosis. And they found a genetic marker on chromosome 19. And many other chromosomes have been implicated in the development of scoliosis. This great study from Ward looking at Central America looked at the Mormon population. And the Mormons came over from the United Kingdom in the 1500s. And they reckon that there are 18 million ancestors. And since 1900, there have been 3 million descendants. And they were able to look at this group, and what they found was that there were an outlier of individuals who were affected with scoliosis. The estimate is that there were 2 families responsible for the development of scoliosis, and that 70% of them have common ancestors in England. One single family had 28,000 descendants by 1920, so you wonder if it's not a fertility gene as well as a scoliosis gene. And what they found was that scoliosis patients had at least a 10th degree relative or closer with scoliosis, whereas controls had an 18th. You had to look 18 generations or 18 cousins away to find an affected individual. But it's a heterogeneous condition, and so that makes the research difficult. And there's one other study which I think is very interesting, looking at congenital scoliosis rather than idiopathic scoliosis. And even in this group, 20% of the families reported an individual with idiopathic scoliosis. And I think that's very difficult to explain. So we look at the development. We have marked anterior overgrowth. The scoliosis develops by buckling. You have 2 linked columns, as I showed you in that very simple model. And the growth is driven by growth plates. And the soft tissues simply respond to tension, and you have balance normally. The initiation is probably in the growth spurt when the kyphosis flattens, and the anterior column outstrips the posterior column. And the precipitating event is probably a very rapid growth in a tall girl with a family history. There may be neurological or mechanical effects. And if we look at scoliosis, small curves can get better because the spine can remodel. Larger curves, though, tend to progress. And what we want to try and develop, and I'll talk about this later, is a balance between growth and tension, and try and make the spine respond more normally with our treatments. It may be that we can find a genetic progression marker which will tell us which individuals are going to progress and which are not. So we look at growth. We have physiological growth. Normally the skeleton likes compression and will grow faster. It doesn't like tension. But then if you look at the pathological stage, when there's a severe deformity, a lot of tension will make the bone grow more, and a lot of compression will stop it growing completely. So what we want to do is to try and push the spine back into the physiological area. So in summary, scoliosis is a torsional deformity of the spine. It's probably caused by asymmetric growth. I think in the majority of cases it's probably genetic, although we're not sure about that at the moment. And there are about a dozen genetic alleles which are implicated in the cause of scoliosis. And there are probably many pathways of pathogenesis. Thank you.
Thank you very much. We'll now move on to bracing for spinal deformity, kind of coming full circle here into some of the etiological causes of progression and deformity. Dr. Rooney, thank you.
In a general sense, in natural history has been pretty well studied in the literature. The science isn't necessarily very good, but what we've been able to determine is that the curve magnitude, the amount of remaining growth, and the curve pattern are best we can tell, are predictive factors for progression of curves. So what is progression? And we know that 3 to 4, maybe 5 degrees of measurement error in the Cobb angle is pretty standard. So anything less than that probably wouldn't necessarily constitute an increase. So in a general sense, again, with bigger curves bigger than about 20 degrees, 5 or 6 degrees of an increase is usually considered an increase in the curve. And for bigger curves, for smaller curves less than 20, usually about a 10 degree increase is considered an increase in the curve. So from all of our natural history data, really what still stands is the standard, is this from the Lonstein study in '84, and it's based on the Risser grade and the curve magnitude. And this is still on the board questions for the variety of different boards. It's the in-service answers usually, and this is a pretty useful guide for trying to figure out which curves are going to progress in which patients. But what is important is that these are just statistics, and individual patients need to be treated individually. So bracing, the history of bracing started really with Milwaukee brace, which was a post-operative brace used in polio. But its post-operative curve correction led to some wider applications, like on the Navy training models for their scoliosis, the Barbie doll. So there are a variety of different brace types. Milwaukee, Boston, Charleston, and the others have all been studied to some degree. And they're really all, for the most part, a variation on a theme of a TLSO. This is a Providence brace. This is just a TLSO. Another Providence brace. The Charleston brace, the bending brace at night, a Boston brace. So the history of the bracing, there have been roughly 25 studies that show bracing is effective in controlling the progression and decreasing the likelihood of surgery. There have been 6 studies that show that bracing is not effective at all, but none of these studies have really been well defined or well designed. So poorly designed that the U.S. Preventive Services Task Force in '93 stated that really there are inadequate evidence to determine whether brace therapy limits the natural progression of the disease in a significant proportion of cases. And that the Scoliosis Research Society echoed that, and they tried to standardize criteria for the adolescent idiopathic scoliosis brace studies. These are just a variety of the different studies that have been done showing bracing for the most part works. Some of the studies show it doesn't work. So the general guidelines for research that the SRS came up was that there should be uniform inclusion criteria, that the patients should be probably less than 10, Risser 0 to 2, and a 25 to 40 degree primary curve, and no previous treatment. And in order to assess the brace effectiveness, they should look at the percentage of patients with less than 5 degrees of progression or greater than 6 degrees of progression, the percentage of patients that have had surgery, the percentage of patients who progress beyond 45 degrees, and they should all have a minimum of 2 years of follow-up. But despite the fact that we don't have good bracing studies per se, the SRS still has guidelines for treatment, and that is progression to greater than 25 degrees or 30 degrees at the presentation, and a RISR of 0 to 3 really is something that should be treated with a brace. So really, to address the bracing versus natural history, the natural history, again, is fairly well followed and understood, but not completely validated by science. Bracing is the same. It's whether your personal preference is to embrace bracing or not. What is important is to follow the patient and allow them to declare their own natural history. And that's it. Thanks a lot.
Well, that certainly gives us the luxury of time. Thank you for that concise summary. We do have some time for questions, and all of our speakers can certainly be asked a question. I'd like to start off with a question to James. And I guess, you know, just being a simple spine surgeon, I need a take-home message. How is what the aspects of the etiology that you discussed, where are those going to go in terms of our treatment?
Well, I think if you can pick out a particular group genetically who you can predict are going to progress, then you might want to treat them much earlier before the curve gets into the 30, 40, 50 degrees. And you may be able to predict who you can brace, who you can treat with non-fusion surgery, and who you have to treat with fusion. So I think that's really where the interest is in the future, in being able to predict how you treat people, who needs treating when, and then, of course, in developing new techniques which don't involve fusing the spine.
You see any interaction between biologic agents and perhaps slowing down asymmetric growth curves or inherent spinal growth asymmetries in the future?
I just don't see biologic agents being effective in scoliosis as the science is at the moment. But it'd be great if you could just inject something into the concave side and make it grow.
Question there.
With the model that you showed with the anterior column and the posterior tension band, when you lengthen the anterior column, then it bulges onto one side. Common sense would tell you that it should bend, if you did it a certain number of times, it should bend equally to the right and to the left. Do you think it's the presence of the heart, or how do you explain the fact that the majority of curves are apex right?
I don't think there's any good explanation for that. I mean, people have always said it's because of the aorta or the heart pushing the spine over. Certainly in the model, you can't predict which way it's going to go, because obviously the model doesn't have any asymmetry at all. But there must be some asymmetry in the spine which tends to make it go to the right rather than to the left.
I wanted to add a little bit to the earlier question about the bracing and scoliosis. We had a very exciting meeting this year in which Dr. Ogilvy extended the work on the Mormon population to now 3,300 patients. And he was able, using 5 genetic markers, to predict those people who will develop a scoliosis greater than 40 degrees or will never develop a scoliosis of 40 degrees. And this is within 95% accuracy. Now, this is really exciting because if that occurs, the whole world of bracing will change. Because if you have a curve that's not going to get worse, you certainly wouldn't brace them. And if you have a curve that's predictably bad, then you will operate very early. And so I think there's going to be a revolution in our thinking about scoliosis treatment. And it may help to explain why we have such poor controlled bracing studies. And so I just add that.
Well, and on that same line, I'd like to ask the problem that we've dealing with patients. And one of the issues always is, how do you get people to wear these things?
Uniformly, compliance has been a problem in the studies, and they've had implantable things on the brace that you can tell what the compliance has been, and it's been 10% in some studies and lower. And bracing isn't necessarily benign. Maybe physiologically it can be benign, but psychologically it's not. In a younger patient with a pliable chest, it's not necessarily benign sometimes either. So I guess rigid parents is probably the best way to get kids to wear a brace, but it's certainly a struggle.
I have a question for Greg. As a basic parameter, aware of a TLSO in any population, how much is it expected to decrease pulmonary function?
Well, it's a good question. It will reduce it to variable extents depending on how much you allow the abdomen to move. So one of the things to think about is that as you brace someone, the only place where you can really move with a brace, if you're really controlling chest wall, is going to be the abdomen. And that's where your diaphragm, actually have room to let your diaphragm go down. Depending on how you construct that, if you reduce abdominal excursion, you get a lot of distress, and kids won't wear it because of that. So a lot of it's in how it's constructed. People overlook the abdomen a lot in terms of how patients tolerate this. You're going to reduce vital capacity, and people have estimated, because you have reduced vital capacity already, if you say how much more do you do it, 10%, 20% easily, depending on the patient and how severe they are.
Do you have an idea of the status of bracing in England for children at the moment? It's just a curiosity, really. Do you think that a lot of surgeons have abandoned bracing altogether?
I think the majority of surgeons abandon bracing, but certainly in our center we still use it widely, and we would use the SRS criteria. I thought it was interesting, though, that the criteria for investigation for the SRS was they were suggesting that we only do clinical trials on much younger patients, and yet the majority of our patients are sort of risk grade 0 to 3, but a lot of them are grade 2 and 3, and that's precisely the group that we want to know whether we can brace or not. I think we know that the very young children respond very well to bracing.
Thank you.